Hello everyone. I am Dr. Omkar Sangita Diliprasanoni, and today I welcome you all back to the session of Sparks presented to you by AFMG. And today's discussion will be about PSM revision and chanting. I hope all of you have been through all the previous revision and chanting sessions of PSM. For you, it is easy to catch up, as you are quite aware that the PSM chanting sessions were on a halt for the medicine test and discussion. So now we'll again restart with our PSM revision and chanting sessions. Mostly in the subsequent two, after this, more subsequent two sessions will be held, with which PSM chanting and revision will come to an end, and then we'll start with ophthalmology as well. Okay, so I hope this is pretty much clear. So let's start our discussion for today. Today's topic will be about maternal and child health, that is preventive obstetrics and pediatrics. Apart from that, we'll also discuss about our important topic, that is demography, and also some few points about occupational health. Okay, so this is all about today's discussion. So let's start. So if we talk about preventive obstetrics, usually we'll talk about the delivery, the period before delivery, and the period after delivery. So the delivery period is known as the natal period. So the period which comes before delivery is known as antenatal period, that is the period of pregnancy, and the period which comes after delivery is known as the postnatal period, right? So the antenatal care, we'll discuss first about antenatal care, that is the period during pregnancy. So if we talk about antenatal care, first important thing that we need to discuss is about the antenatal visits. Okay, so when the pregnant lady comes to the healthcare system or to the hospital, these are known as your antenatal visits. So if we talk about the recommended number of antenatal visits, those are 13 to 14. So please remember, the recommended number of antenatal visits are 13 to 14. Recommended antenatal visits are 13 to 14. Out these 13 to 14s are actually distributed. How are those? So please remember, in the first 7 months of pregnancy, that is from 0 to 7 months of pregnancy, the visit should be once a month. The visit should be once a month, making it a total number of 7 visits. Next, in the 8th month of pregnancy, the visit should be twice a month. In 8th month of pregnancy, it should be twice a month, means 2 visits. And lastly, 9th month onwards, the visit should be once a week. In the last month, that is 9th month onwards, the visit should be once a week, which makes it of a total of 4 to 5, because sometimes the pregnancy terminates at 9 month itself, sometimes it extends also. Okay, so this would be a total number of 13 to 14 visits. So 13 to 14 are the recommended antenatal visits. This is one question. If we talk about the minimum antenatal visits, this question was talking about the recommended antenatal visits. But if we talk about minimum antenatal visits, because in a country like India, usually 13 to 14 visits are not actually seen. So what are the minimum number of visits that should be done? So please remember, the minimum number of antenatal visits are 4. So more than equal to 4 is the minimum number of antenatal visits. Out of these 4 visits, the first visit should be for registration in this RCH program. So what do we mean by this RCH program? RCH, the maternal and child health, actually comes under the RCH program. That means reproductive and child health program, which was launched in the year 1997, which now comes under a umbrella health program known as the National Health Mission, about which we have discussed in details earlier, right? So this National Health Mission, launched in 2013, also covers this reproductive and child health program now, right? So now, according to this RCH program, minimum number of antenatal visits are 4. So first visit should be registration under this program. Second visit should be in the second trimester, that is between 14 to 26 weeks period of gestation. Third visit should be in the third trimester almost, that is 28 to 34 weeks period of gestation. And last visit should be in the 9th month, that is from 36 week onwards till delivery. So what are the minimum number of antenatal visits? They are 4. First for registration, second between 14 to 26 weeks, third between 28 to 34 weeks, and last between 36 weeks to delivery. I hope this is clear. Now, if we talk about the visits after delivery, that is, those are known as postnatal visits. Now, if we talk about the postnatal care, PNC, the minimum number of postnatal visits are 3 number. But now this time the lady would not come to the hospital, rather the healthcare worker will go to the house. Okay, so these are known as your postnatal visits, and the minimum number of postnatal visits are 3. Okay, and these postnatal visits are done by whom? These postnatal visits are done by auxiliary nurse midwife or multipurpose worker female. याद रख लेना, these postnatal visits are done by auxiliary nurse midwives known as ANMs or multipurpose worker female. Multipurpose worker female is located at which center? She is located at the sub center. So both like either of these healthcare workers will go to the house and do a postnatal visit to assess the status of the mother and the child. Right. So the first visit should be done within the first 3 days of delivery. Next should be on the 7th day, that is 1 week, and the last should be within 42 days or the 8 weeks of delivery. Okay, so the 3 visits are recommended within 3 days, 1 week, and 8 weeks. These are the postnatal visits, minimum 3 in number, done by ANM or multipurpose worker female. Apart from these postnatal visits, we also have one more healthcare worker who will visit the female, and that healthcare worker is known as ASHA, who is located at the village level. So the ASHA worker will visit the house. So these are known as ASHA postnatal visits. Okay, so ASHA postnatal visits, how much are they? So the ASHA postnatal visits are 6 to 7 in number. So the ASHA will visit the house 6 to 7 number of times. Okay, when are they 6 and when are they 7? So please remember, in cases of home deliveries, when the child is being delivered at home, the visit should be 7 in number. That is, the visit should start on the delivery day itself. That is day 0, day 3, 7, 14, 21, 28 and 42. So every week the visit should be there. Okay, 0, 3, 7, 14, 21, 28 and 42. Total a number of 7 visits in cases of home deliveries by ASHA worker. Whereas in cases of institutional deliveries, when the child is being delivered at the hospital, the number of visits should be 6 in number. Okay, the number of visits should be 6 in number because the first day the child would be in the hospital still. Therefore, the first visit is not recommended. We start from day 3. So the visits in cases of institutional deliveries would be on day 3, 7, 14, 21, 28 and 42. So rest of all the things will remain same except for the day 1 or day 0. Okay, I hope this is clear to you. Now moving further, talking about the MCH indicators. So the maternal and child health have various indicators. Okay, and these various indicators can tell us about the maternal and child health, right? So let's discuss about those important ones. First is your infant mortality rate, also known as IMR. So infant mortality rate or IMR का formula क्या होता है? Total number of infant deaths upon total live births into 1000. So this is a rate as the multiplier is 1000, right? So total number of infant deaths upon total live births into 1000 is the infant mortality rate. What is the current infant mortality rate of India? So the current infant mortality rate of India is 32 per 1000 live births. Current IMR of India is 32 per 1000 live births according to the recent sample registration survey. You will see according to census 2011 it was 34. Okay, but the recent SRS says it is 32 per 1000 live births. Next, talking about MMR, that is maternal mortality rate, or you can also say it as maternal mortality ratio because it is a ratio MMR. Okay, so what is the formula for MMR? MMR or maternal mortality rate is total number of maternal deaths upon total live births into 1 lakh. So here the multiplier is 1 lakh. So therefore it is not a rate, it is a ratio. And A is not part of B. That is, maternal deaths are not a part of total live births, right? So please remember, maternal mortality rate का formula होता है maternal deaths upon total live births into 1 lakh. It is a ratio, second thing. And third thing, the current MMR of India is 113 per 1 lakh live births. Current MMR of India is 113 per 1 lakh live births. Yes, according to census 2011, it was 130 per 1 lakh live births. But according to recent SRS, it is 113 per 1 lakh live births. Now, I hope this is clear. Apart from this, 2 important indicators of MCH, we also have the other indicators like the neonatal mortality rate, when the deaths in the first 28 days of life are only considered, because a neonate is a baby within first 28 days of life, right? Next is under 5 mortality rate. Next is the stillbirth rate. Okay, stillbirth is considered when the child is more than 28 weeks period of gestation, or when the birth weight is more than 1000 grams, or when the birth length is more than 35 centimeters. In only these conditions, the child would be considered the dead child would be considered as a stillbirth. Okay, now apart from this, there is also one important mortality indicator that is known as perinatal mortality rate. And what do we mean by perinatal? So please remember, perinatal means around delivery. right? And what is the perinatal period then? So the definition of perinatal period would be from 28 weeks period of gestation till 7 days post delivery. So please remember guys, perinatal mortality rate or the perinatal period is defined as the period from 28 weeks period of gestation till 7 days post delivery. I hope this is clear. Moving further. Now talking about, these were all the MCH indicators. Now we'll talk about an important thing, that is iron folic acid tablets. As we all know, usually the Indian females are at a risk of developing anemia during pregnancy and lactation because the bodily demands have been increased in this period. Therefore, iron and folic acid tablets are to be supplemented to this pregnant and lactating females. So what is the dose of iron and folic acid in these tablets? So please remember, usually the iron and folic acid tablet dose is around 100 milligram of elemental iron and 500 microgram of folic acid. What is the dose? 100 milligram of elemental iron and 500 micrograms of folic acid. Okay, so iron is given to just prevent iron deficiency anemia, whereas folic acid is also given to prevent megaloblastic anemia. Along with that, it is also given to prevent neural tube defect, which is a congenital anomaly seen in the fetus, right? So neural tube defects are seen in cases of folic acid deficiency. Usually in cases where the female have already had a pregnancy with neural tube defect, means there is a history of neural tube defect pregnancy in a female, then this is considered as a high risk pregnancy, and in this condition the folic acid dose is usually 10 times. That means it is almost 10 times, that is 4 mg. Then the tablet of folic acid will be given in which dose? 4 mg dose. Yaad rakh lena. I hope this is clear to you. What is the normal dose of iron? 100 mg elemental iron. Folic acid 500 micrograms of folic acid. Okay, iron folic acid tablets are not only given to pregnant and lactating females, they are also given to reproductive age group females, adolescent girls, and children between 6 months to 5 years of age. Okay, please remember this. Now if we talk about this iron and folic acid tablets, usually they are red in color, which is given to this pregnant females, okay, lactating females, and the duration is 180 days. Yaad rakh lena, the total duration to give these tablets is 180 days. Okay, next talking about an important vaccine that usually pregnant females get, that is tetanus toxoid vaccine. Okay, as we have already discussed in the vaccination session, that vaccination for boys is completed at 16 years of age, but whereas in girls it is continued beyond 16 years of age when the pregnant females receives 2 doses of tetanus toxoid vaccine. How many doses? 2 doses of tetanus toxoid vaccine are given in pregnancy, and how many weeks apart? 4 weeks apart. So a gap of 4 weeks or 28 days is maintained between these 2 doses of tetanus toxoid given during pregnancy, right? So now if a question comes like a female was pregnant, she delivered, she got 2 doses of tetanus toxoid already in the first pregnancy. Now the female is pregnant again within a period of 3 years. Now if the period is pregnant again within a period of 3 years itself, in this pregnancy the female will only and only get a TT booster. The female only and only should get a tetanus toxoid booster. She does not require again 2 doses if the subsequent pregnancy occurs within 3 years itself. But if the subsequent pregnancy occurs beyond 3 years, definitely she'll require the full dose, that is full 2 doses of tetanus toxoid. I hope this is clear. How many doses? 2 doses. How many weeks apart? 4 weeks apart. Okay, in pregnancy. And if pregnancy occurs within 3 years of the last one, then TT booster only. Moving further, talking about the other things now, talking about pediatrics, now some important points in pediatrics. Now talking about the average birth weight. Average birth weight of an Indian child. The average birth weight of an Indian child is 2.8 to 2.9 kg. Average birth weight of an Indian child is 2.8 to 2.9 kg. Usually we can say the birth weight ranges from 2.5 to 4 kg. Birth weight ranges from 2.5 to 4 kg. Less than 2.5 is considered as low birth weight, and more than 4 kg is considered a large baby or a macrosomiac baby. And more than 4 kg baby or a macrosomiac is usually an infant of diabetic mother. The pregnant females who are suffering from gestational diabetes mellitus usually have macrosomiac babies, right? Important. Now if we talk about low birth weight, okay, there is a WHO classification which is accepted for low birth weight of a child. Okay, low birth weight is when the birth weight is less than 2.5 kg. Birth weight of less than 2.5 kg is considered low birth weight. Birth weight of less than 2 kg is considered moderately low birth weight. Less than 2 kg is moderately low birth weight. Birth weight less than 1.5 kg is very low birth weight. Weight less than 1.5 kg is very low birth weight. And a birth weight of less than 1 kg is extremely low birth weight. Weight less than 1 kg would be extremely low birth weight. याद रख लेना. Now, what is the field instrument used by healthcare workers to measure weight? So please remember, when a healthcare worker goes into the community and if he requires to, if he needs to measure weight of the children, the field instrument used by him would be the Salter scale. The image I have shown already in session 1 and session 2. So please remember, it is the Salter scale. When a child is actually hanged to that scale, again the weight is measured. Okay, so Salter scale is the field instrument used to measure weight of a child in ICDS activities usually. Right? Yaad rakhna. Next, talking about the next one, next indicator of health of a child, that is birth length. Okay, so the average birth length of a child would be 50 centimeter. Average birth length of a child would be 50 centimeter, and the field instrument which is used to measure birth length is infantometer. The field instrument used to measure length is infantometer. Length is when, so please remember, less than 2-year child, we will measure the length. Okay, if the child is less than 2 years, then we'll measure the length. But if a child is more than 2 years, now then we'll measure the height. If a child less than 2 years is there, we'll measure the length by infantometer. And if a child is more than 2 years, we'll measure the height by which field instrument? By stereometer. Okay, I have shown the images of these two as well. So more than 2-year child will measure height with the help of stereometer. Please remember this. Okay, now 2 important questions from pediatrics that are very much important. So please remember, first of all, birth weight doubles by what age? So please remember guys, birth weight usually doubles by 5 months of age. Birth weight usually doubles by 5 months of age, whereas birth weight triples by 1 year of age. Birth weight triples by 1 year of age. Okay, and if they ask birth length at 1 year is how much? So please remember, birth length at 1 year is 75 centimeter. Birth length at 1 year is 75 centimeter. That means there is a 50% increase. There is a 50% increase in the birth length. Whereas birth length doubles by 4 to 4.5 years of age. Birth length doubles by 4 to 4.5 years of age. I hope this is clear to you. Important question. Moving further now, if we talk about other indicators of malnutrition or growth, those are your skin fold thickness. And as we have already seen in the image section part, skin fold thickness is measured by which instrument? It is measured by Harpendon's calipers. Skin fold thickness by Harpendon's calipers. Next one, talking about one more important one, that is mid-upper arm circumference or mid-arm circumference, also known as MAC. So this mid-arm circumference or MAC is measured by which field instrument? It is measured by Shakir's tape. So it is measured by which field instrument? It is measured by Shakir's tape. And a MAC of less than 12.5 centimeter is considered malnutrition. I hope you have already seen Shakir's tape. It has 3 zones. The green zone indicates normal children, yellow zone indicates borderline children, and red zone indicates malnourished children. So red zone comes when the mid-arm circumference is less than 12.5 centimeter, which is suggestive of malnutrition. And if the mid-arm circumference is less than 11.5 centimeter, this is a cutoff usually used for SAM. So a MAC of less than 11.5 centimeter, these children are considered SAM, that is severe acute malnutrition. Severe acute malnutrition less than 11.5 centimeter. So this is about all the indicators used for growth assessment. Now talking about breastfeeding, a very important topic. Now breastfeeding is usually of 2 types. First is exclusive breastfeeding and second is complementary breastfeeding. What do we mean by exclusive breastfeeding? That the child only and only gets breast milk. Okay, so yaad rakhna, child only and only receives breast milk, not even water. So this type of exclusive breastfeeding is recommended till 6 months of age. So please remember, till 6 months of age, in the first 6 months of lactation, the child should receive only and only exclusive breastfeeding. Whereas after 6 months of age, the child is also given some other complementary foods like Cerelac ho gaya, okay, all these dal and all of these are substituted. So please remember, then it is known as complementary breastfeeding and it is started after 6 months of age till 2 years. Okay, it is recommended after 6 months of age till 2 years. That is known as complementary breastfeeding. Yeah, right now, okay. And exclusive breastfeeding have shown very effective results. Okay, please remember this. Now, what is the time when we initiate breastfeeding? So please remember the time to initiate breastfeeding if the question comes like this. So the best answer should be as soon as possible. So please remember guys, the best answer to this question, when should breastfeeding be initiated? It should be initiated as soon as possible. This is the best answer, ASAP. Okay, if it is not an option, then half hour, not an option 1 hour, not an option 2 hours, not an option 4 hours. Okay, so please remember as soon as possible should be the best answer. If as soon as possible is not in the option and they ask you like in normal vaginal deliveries in NVDs, what is the time in which breastfeeding initiation should be done? It should be done maximum within 1 hour. Whereas in cases of C sections, it should be maximum done within 4 hours. Okay, not years, hours. Okay, so it should be maximum done within 4 hours in cases of C section. If they talk about a normal vaginal delivery, please remember guys, if as soon as possible is not an option, one half hour or 1 hour would be the best answer. Or if a better answer is also there, that would be at the delivery table itself. So please remember, at delivery table itself can be a good answer, because if breastfeeding in cases of normal vaginal delivery is started at the delivery table itself, this breastfeeding will help release oxytocin. And as we are quite aware of the fact that oxytocin is a hormone which will prevent PPH. So the incidence or risk of postpartum hemorrhage decreases substantially if breastfeeding is actually started at the delivery table itself. Okay, I hope this is clear. Moving further. Now talking about the most abundant immunoglobulin. If we talk about the breast milk, or for that matter any of the bodily secretions like saliva or colostrum, any of these, okay. So in all these secretions, the most abundant immunoglobulin found is IgA. Most abundant immunoglobulin found in breast milk is IgA. Yaad rakhna, IgA. Yaad rakhna, question has come twice. Next one, if we talk about a fatty acid, essential fatty acid. Essential means which has to be taken from outside, right? Which is not synthesized in the body. So talking about this question, which is the essential fatty acid present in breast milk? So please remember, the essential fatty acid present in breast milk is DHA, that is docosahexaenoic acid. It is known as docosahexaenoic acid, also known as DHA. It is also known as cervonic acid. It is also known as cervonic acid. And this DHA, docosahexaenoic acid or cervonic acid, is responsible for CNS or brain development. Okay, it is responsible for CNS development. Next, talking about a amino acid which is present in breast milk. An important amino acid present in breast milk would be taurine. Yaad rakh lena, an important amino acid present in breast milk is taurine. And taurine is responsible for myelination. Yaad rakh lena, taurine is responsible for myelination. Therefore, it is also important factor for CNS development. So the two factors which are important for CNS development present in breast milk. First is the essential fatty acid known as cervonic acid. Second is the important amino acid known as taurine. Right? Now, if the question comes like which is the most deficient vitamin in milk, I'm talking about milk overall, not only about human milk or breast milk. Okay, if I talk about most deficient vitamin in milk, so please remember vitamin C is the most deficient vitamin in the milk. Okay, vitamin C is the most deficient vitamin in milk. But if I change my question to most deficient vitamin in breast milk, now I only want to know about most deficient vitamin in breast milk, then my answer would change to vitamin D. Then my answer would change to vitamin D. Now, most deficient vitamin in milk overall is vitamin C, but most deficient vitamin in breast milk is vitamin D, and that is why vitamin D is acquired from sunlight in newborns. Okay, newborns are kept in the early sunlight, first thing, and second, vitamin D is also given. Okay, injections of vitamin D are usually given. Okay, injections of vitamin D are usually given till 1 year of age. Yaad rakh lena, injections of vitamin D are given to the infants till 1 year of age, and the dose is 400 international units. Okay, yaad rakhna, the dose is 400 international units. Okay, one more vitamin is usually substituted, and that is vitamin K. But vitamin K is only given as a single dose. याद रख लेना, vitamin K का बस एक single dose दिया जाता है at birth itself, and it is to prevent hemorrhagic disease of the newborn. याद रख लो. Okay, moving further. Now, if we compare cow milk on one hand and breast milk on other hand, So then cow milk will have certain substances which will be higher in quantity, and breast milk will have some other substances which will be higher in quantity, right? So let's discuss about these comparison because questions have been asked. So higher amount of protein is found in cow's milk. याद रख लेना, higher amount of protein is found in cow's milk, whereas higher amount of lactose, that is carbohydrate. So higher amount of lactose or carbohydrate is found in breast milk. Higher amount of lactose or carbs is found in breast milk. Higher amount of iron is found in breast milk. Higher amount of iron is found in breast milk. Higher amount of calcium and phosphate. If we talk about the quantities of calcium and phosphate, they are found in higher quantities in cow milk. But if we talk about the ratio, that is the calcium phosphate ratio. If we talk about the calcium phosphate ratio, it is high in breast milk. याद रख लेना, the calcium phosphate ratio is high in breast milk, and calcium phosphate ratio is the important calcium phosphate ratio is actually required for absorption of calcium. So याद रख लेना, जितना ज्यादा calcium phosphate ratio होगा उतना better calcium और phosphate का absorption होगा. Therefore better calcium and phosphate absorption takes place in breast milk, not in cow's milk. याद रखो. Okay, I hope this is clear to you. Now moving further, and the first breast milk within first 2 to 3 days after delivery is known as colostrum, which is high in all the antibodies वगैरह. Okay, and the most abundant antibody we have discussed, it is IgA, right, in breast milk. And this transmission of antibodies from mother to child is known as vertical transmission of antibodies. And this is actually which type of immunity? This is actually a natural acquired immunity. Naturally आ रही है, but mother से आ रही है, से acquired. Okay, natural acquired immunity का example है vertical transmission of immunoglobulins. I hope this is clear. Moving further now, talking about some best indicators for growth, development and nutrition. If a question comes, which is the best indicator to assess growth, development or nutrition? So if a single indicator is to be named, then the best indicator used to assess growth, development or nutrition, the answer should be weight. याद रख लेना, the best indicator used to assess growth, development or nutrition is weight. Next one, if now we talk about malnutrition. Okay, if we talk about malnutrition, there are different types of malnutrition, right? So first is acute malnutrition. Acute malnutrition mein the best indicator would be weight for height. Acute malnutrition mein the best indicator is weight for height, where there is a graph. On x-axis there would be weight and y-axis will have height on it. Okay, so acute malnutrition will be weight for height. Chronic malnutrition is assessed by height for age. Chronic malnutrition is assessed by height for age. And lastly, acute on chronic malnutrition. That is, a child is suffering from chronic malnutrition and suddenly he is deprived of all the food, okay, all the energy. Then this is the child would land in acute on chronic malnutrition, and it is best assessed by weight for age. It is best assessed by weight for age. याद रख लेना. So if acute malnutrition is there and there is decrease in weight for height, this condition is known as wasting. Decrease in weight for height is known as wasting. And if there is chronic malnutrition and there is decrease in height for age, decrease in height for age is actually known as stunting. Decrease in height for age is actually known as stunting. So wasting is seen in acute malnutrition. Stunting is seen in chronic malnutrition. I hope this is clear. Moving further, right, we have discussed about this in details now. MAC, that is mid-arm circumference. Shakir's tape is used to assess MAC. Okay, less than 12.5 centimeters is the cutoff for malnutrition. Less than 11.5 centimeters is the cutoff for severe acute malnutrition. Enough to know. Moving further, talking about growth charts now. We have also discussed about growth charts in the images. We have actually two types of growth charts for children for their assessment of growth. So that are WHO growth charts, which are accepted worldwide, and second are ICDS growth charts. ICDS is Integrated Child Development Services, which is an activity undertaken under the RCH program in India. So we also have ICDS growth charts, right? So usually the WHO growth charts are of two types. First are the percentile based growth charts, and second are the Z-score or standard deviation based growth charts. Z-score and standard deviation we'll discuss in details in biostatistics. Okay, I hope this is clear. So percentile, that is 5th percentile, 10th percentile. So those are your percentile based growth charts. We have discussed it in details in session 1 and session 2. You can refer to those sessions, right? And usually, as we all have, all are quite aware that boys and girls have different growth charts. Usually girls growth charts are pink in color and boys growth charts are blue in color, right? Moving further, now we talk about school health. Okay, so the school health was first time recommended by which health committee? It was recommended by the Bhor committee. Okay, the oldest committee. So school health was recommended by which committee? Bhor committee. School health was recommended by which committee? Bhor committee. But if the question comes that comprehensive school health program was recommended by which committee? So please remember, comprehensive school health program was recommended by the Renuka Roy committee in the early 1970s. Okay, yaad rakh lena. Comprehensive school health program was recommended by the Renuka Roy committee. Okay, moving further now. Under the recommendations of these committees, the one classroom should contain less than 40 students. Okay, they say one classroom should have less than 40 students, which is not a case in India actually. Next one, the per capita space for each child should be 10 square feet. Per capita space per student should be 10 square feet. Next, the desk should be of minus type. Usually all of us have been in schools. So these were the type of desk which we had. That is the writing surface and the sitting surface were overlapping each other. This is known as a minus type of desk. So which types of desk are recommended? Minus types of desk are recommended to keep usually the spine straight. Next, one urinal per 60 students is recommended. One urinal per 60 students is recommended. And one sanitary latrine per 100 students is recommended. One sanitary latrine per 100 students is recommended. And lastly, the school health examination frequency. Okay, the school health examination is undertaken every 6 months. It is undertaken every 6 months. Here we'll also discuss about one more thing, that is under the NPCB VI program of India, which we have discussed. We also have a school vision testing program. Okay, where one teacher actually screens how many students? One teacher actually screens 150 students, and this is the responsibility of the class teacher. One teacher per 150 students, and the child is referred if the vision is less than 6/9. If the child's vision is less than 6/9, the child is referred to the vision center to the paramedical ophthalmologic assistant, and there he again checks the vision and then recommends the spectacles or the glasses. Okay, I hope this is clear to you. Moving further now. Moving further, talking about the school vision screening program, this we have discussed, done by the class teacher. One teacher per 150 students. Referral is done if the vision is less than 6/9. Geriatrics. Geriatrics is the study of population more than 60 years of age. Okay, geriatrics is the study of population more than 60 years of age. Yaad rakhiye na. Next, if we talk about JSSK, we have spoken in details about JSSK in all the other healthcare programs. JSSK, Janani Shishu Suraksha Karyakram, under which there are some maternal, whereas some newborn benefits given by the Health and Family Welfare Ministry of India. Next, talking about ICDS. ICDS means Integrated Child Development Services, which comes under the Ministry of Women and Child Development. Okay, ICDS comes under the Ministry of Women and Child Development, the heart of which is Anganwadi. So heart of ICDS activities is Anganwadi Center, whereas the functional unit of ICDS activities is a Community Development Block. Functional unit of ICDS activity would be Community Development Block. Heart, Anganwadi. Functional unit, Community Development Block. And one community development block usually consists of 100 villages or 1 lakh population. One community development block consists of 100 villages or 1 lakh population. The beneficiaries under this ICDS activities would be children between 0 to 6 years of age, pregnant and lactating females, reproductive females in the 15 to 49 years of age group. So please remember, reproductive age group is between 15 to 49 years. Yaad rakhna. And lastly, adolescent females between 11 to 18 years. Like adolescents once are the 11 to 18, right? So these are all the beneficiaries under the ICDS activity. I hope this is clear to you. Now, moving further, the midday meal program. So midday meal program comes under the Ministry of Education. It is providing meals in schools to the children. So it comes under Ministry of Education, under which 1/3 of the daily calorie requirement and half of the daily protein requirement is given to the child. Okay, 1/3 of the daily calorie requirement and half of the daily protein requirement is being given to the child under the midday meal scheme. Moving further, talking about a very important topic now, that is demography. Okay, what do we mean by demography? So yaad rakhna, demography means scientific study of the human population. Okay, the number, the changes, okay, all of these would be spoken in the demography itself. Okay, so human population ka ek scientific study with all the indicators is actually known as demography. So there are different demographic indicators which tells us about the demography of our population. So the most important indicator are these two, that is crude birth rate and the crude death rate. Okay, so crude birth rate का formula क्या है? Total births upon mid-year population into 1000. So what is the formula? Total birth upon total mid-year population into 1000. So 1000 is the multiplier, therefore it is a rate, right? So this is the formula for crude birth rate. What is the current crude birth rate of India? Forget this. It is 20.2. Crude birth rate of India currently is 20.2. Crude birth rate of it currently is 20.2. What is the formula for crude death rate then? The formula for crude death rate is total number of deaths upon mid-year population into 1000 again. The multiplier is 1000, therefore it is again a rate. So crude death rate ka formula is total number of deaths upon mid-year population into 1000. What is the current crude death rate of India? So the current crude death rate of India is 6.2. Current death rate of India is 6.2. So current CBR was 20.2. Current CDR was 6.2. I hope this is clear. Now you all might be confused at what is mid-year population. So please remember, usually the population is calculated on 1st of January, but when the population is calculated on 1st of July, it is considered as the mid-year population. So mid-year population means population calculated on 1st of July. Okay, and 1st of July, as we are quite aware of that, it is also celebrated as National Doctors Day. Okay, 1st of July is also celebrated as National Doctors Day. Then if we talk about next one, that is doubling time of India. So what is the duration in which the population of India will get doubled? So the duration in which the Indian population can double is 35 to 47 years. Okay, we can estimate the doubling time of India, which is 35 to 47 years. Yaad rakh lena, okay? Now we talk about the demographic cycle. Important one, we talk about the demographic cycle. So now this demographic cycle has various 5 stages, and those are important to know. Okay, we have already discussed in the image based part. Let's discuss it over here also. So demographic cycle ka first stage is known as the high stationary stage. First stage is known as the high stationary stage. Here we'll consider the crude birth rate, the crude death rate, and lastly we'll also talk about the demographic gap. What do we mean by demographic gap? So please remember, growth rate or demographic gap ka formula kya hai? Crude birth rate minus crude death rate. What is the formula for growth rate or demographic gap? So the formula would be crude birth rate minus the crude death rate. The difference in between these two, right? That is your demographic gap. So let's discuss about stage 1, that is high stationary stage. So in high stationary stage, there would be high crude birth rate whereas high death rate. So high birth rate and high death rate are seen. The population is stable or stationary at this point of time. Okay, so the population would be stable or stationary in this stage. Yaad rakh lena, because both of them are increasing. Therefore, the demographic gap would be minimum. Right. Next, talking about stage 2. Stage 2 is also known as early expanding stage. Stage 2 is also known as early expanding stage. In this, what happens usually, the population now starts to expand. And how will it expand? So please remember, the crude birth rate is still increasing. Crude birth rate is still increasing, but the crude death rate has started declining now. The crude death rate have started declining. So this is how what happens, the population starts to expand. Okay, yaad rakhna. Next, we'll talk about stage 3. Stage 3 is known as the late expanding stage. Late expanding stage. What happens in late expanding stage? So please remember, in late expanding stage, the crude death rate is already declining. The crude death rate is already declining, but the crude birth rate also starts declining. The crude birth rate also starts declining. But please remember, here the death rate would decline faster. Yaad rakh lena, here the death rate is declining faster. Okay, and crude birth rate has just started declining. Okay, this is known as the late expanding stage. Next one, stage 4. It is known as the low stationary stage. Stage 4 known as the low stationary phase. इसमें क्या होता है usually? In this, the crude birth rate is also declining and the crude death rate is also declining. So both of them are declining, therefore the population is again stable. The population is stationary. Therefore the demographic gap again becomes minimum in stage 4. So demographic gap is minimum in stage 1 and stage 4. And last is your stage 5, that is known as the declining stage. Last is your stage 5 known as the declining stage. So in this, what usually happens is, crude death rate, crude birth rate both were declining, but now the crude death rate will decline, but crude birth rate will decline faster. Crude birth rate is declining faster. मतलब birth कम हो रहा है, Okay, so इसमें क्या हो रहा है, बर्थ कम हो रहे हैं, डेथ तो उसी जगह पे है. So what will happen? Now the demographic gap would be reversed. So there would be a negative demographic gap or a inverse demographic gap. Okay, you can see the image based part. I have explained the graph over there, so it will be easier for you to understand. Okay, we have discussed all of this. Then India is in which phase of demographic cycle? So please remember guys, India is in stage 3 of demographic cycle. So India is in which stage of demographic cycle? India is in stage 3 of demographic cycle, that is the late expanding stage. याद रखना, it is the late expanding stage. I hope this is clear. Okay, please remember this. Now if we talk about maximum demographic gap, so please remember maximum demographic gap is seen in late stage 2. Maximum demographic gap is seen in late stage 2. Okay, it is seen in late stage 2. Minimum demographic gap was seen in stage 1 and stage 4 because the population was stationary. Minimum demographic gap in stage 1 and stage 4. Whereas negative demographic gap was seen in stage 5. Negative or inverse demographic gap was seen in stage 5. That is the declining stage. I hope this is clear to you. Then we can move further. Okay. And one more important point that you need to remember is demographic gap starts contracting. Demographic gap starts contracting at which stage? So it starts contracting in early stage 3. It starts contracting in early stage 3. Okay. Moving further now. We spoke about demographic gap, that is also known as growth rate. What is the formula? Crude birth rate minus the crude death rate. Right. This was the formula. So if we talk about growth rate of India, so the annual growth rate of India, if we talk about per year, Indian population increases by 1.64%. So the annual growth rate of India is how much? 1.64%. Annual growth rate of India is 1.64%. But if we talk about the decadal growth rate of India, so the decadal growth rate of India is 17.64%. Decadal growth rate of India is 17.64%. I hope this is clear. Now moving further, talking about some important demographic indicators, also known as fertility indicators. ठीक है, so उनके बारे में अगर हम बात करें now, so the first one important fertility indicator is TFR, that is your total fertility rate, also known as completed family size. Okay, so the first important fertility indicator is total fertility rate, also known as completed family size. It means what? It means total number of children, okay, total number of children born to a female in her entire reproductive lifespan. Total number of children born to a female in her entire reproductive lifespan is considered as the total fertility rate or completed family size. Right. Next one, talking about general fertility rate. What is the formula for general fertility rate? So please remember the formula for general fertility rate is total number of live births upon mid-year population of reproductive age group females into 1000. The formula for general fertility rate would be total number of live births upon mid-year population of reproductive age group females, that is females between 15 to 49 years, into 1000 is the multiplier. Right, so it is the general fertility rate. Next, if we talk about GMFR, that is general marital fertility rate. General marital fertility rate, it is same as GFR, just one change is seen. What is that? Numerator remains same, that is total live births. Denominator mein now we have a change, that is mid-year population of married reproductive age group females. Here the denominator changes, mid-year population of married reproductive age group females into 1000. Okay, so that is your general marital fertility rate. Next is your GRR, that is gross reproduction rate. GRR is your gross reproduction rate. It is total number of, okay, it is total number of girl children, born to a female in her entire reproductive lifespan. Okay, so total number of girl children born to a female in her entire reproductive lifespan is considered as gross reproduction rate. Reproduction means why only girl children are considered? Because girls are only able to reproduce. Okay, that is known as your gross reproduction rate. Next is your net reproduction rate. So net मतलब क्या? पूरा कैलकुलेशन करके. So net reproduction rate में क्या है फॉर्मूला? It is total number of girl children. Okay, it is total number of girl children born to a female in her entire reproductive lifespan minus the mortality. So please remember, total number of girl children born to a female in her entire reproductive lifespan taking into account the mortality is your net reproduction rate. मतलब यहाँ पे क्या consider किया हमने? Mortality. That is, please remember, if a female had 4 girl children, that was her gross reproduction rate. But out of these 4 girl children, 2 of the girls died. Okay, 2 of the girls died. So that was the mortality. So while calculating net reproduction rate, how much would be the net reproduction rate of this female? Only 2, because 2 of them have already died. So mortality should be reduced from NRR. So याद रखना net reproduction rate में mortality is not considered. I hope this is clear. Now, as mortality is not considered in NRR and it is the only fertility indicator where mortality is taken into account. Okay, only fertility indicator where mortality is taken into consideration is net reproduction rate. Therefore, the most important fertility indicator would be NRR. Most important fertility indicator would be NRR. I hope this is clear. So now the current NRR of India is 1.2. Current NRR of India is 1.2 and current TFR of India is 2.2. Current TFR of India is 2.2. Now, if we talk about this, so please remember, sorry, according to the National Health Mission, we have discussed about National Health Mission already. So according to the National Health Mission, the total fertility rate of India, there is an aim to reduce it to less than 2.1. Currently it is 2.2. Now according to NHM, the goal is to reduce it to less than 2.1. But to achieve a TFR of 2.1, we need to achieve an NRR of 1. We need to achieve an NRR of 1. It is 1.1, sorry. Currently it is 1.1. And to achieve a TFR of 2.1, our NRR should be 1. Okay. And to achieve an NRR of 1, the couple production rate, okay, the couple production rate should be more than 60%. The couple production rate should be more than 60%. What do we mean by the couple production rate? It means the eligible couple using contraception. Okay, so currently the rate is around 54 to 56. It should be more than 60% to achieve an NRR of 1. Then we will be able to achieve a TFR of 2.1. I hope this is clear. Moving further, talking about ideal contraception. Now we have different methods of contraception, but the best or the ideal method of contraception would be sterilization. Best or ideal method of contraception is sterilization, right? In males it is usually performed by vasectomy and in females it is usually performed by tubectomy. Then if they ask about ideal contraception from both of these methods, then the answer should be vasectomy. Please remember, vasectomy, non-scalpel vasectomy in males is considered superior and ideal contraception. Okay, so Pearl index of vasectomy is only 0.1%, whereas Pearl index of tubectomy is 0.2%. Not much of a difference is there, but the ideal one should be vasectomy. But most commonly performed one, if they ask you most commonly performed one, then it is tubectomy, because males in India don't usually undergo sterilization procedures. It is the female who is always actually asked for sterilization. Okay, it is tubectomy more commonly performed. Ideal one is vasectomy. Moving further now, talking about the sex ratio. Okay, if we talk about the sex ratio of India, what is the first of all sex ratio का formula क्या है? So the sex ratio is described as total number of females upon total number of males into 1000. Okay, what is the formula? Total number of females upon total number of males into 1000, or we can also say it as number of females per 1000 males. The current sex ratio of India according to the census 2011 is 943. The sex ratio of India according to census 2011 is 943. Sex ratio in India is highest in the state of Kerala. Sex ratio in India is highest in the state of Kerala, which is 1084. That is 1084 females per 1000 males. Whereas the sex ratio in India is lowest in the lowest if they ask overall. Okay, if they only ask lowest, then it is lowest in the Union Territory of Daman and Diu. याद रख लेना, in Diu Daman we have the lowest sex ratio of 616 only. याद रख लेना, but it is a union territory. If they ask about a state, then the answer should be Haryana. याद रख लेना, if they ask about the lowest sex ratio is in which state of India, then the answer would be Haryana. Okay, next is about your child sex ratio. What is the formula for child sex ratio? So please remember, the formula for child sex ratio is female children, girl children between 0 to 6 years of age upon male children between 0 to 6 years of age into 1000. Okay, so please remember, 0 to 6 year girl per 1000 0 to 6 year male boys is the child sex ratio. Okay, so the current child sex ratio according to 2011 census is 919. Current child sex ratio in India is 919, which is highest in the state of Mizoram. Okay, it is highest in the state of Mizoram, whereas it is lowest in the state of Haryana again. It is lowest in the state of Haryana, and this is due to female infanticide or female feticide. Right, now let's talk about the dependency ratio. What do we mean by dependency ratio? Dependency ratio means the non-earning population upon the earning population. So dependency ratio is also calculated as population less than 15 years plus population more than 65 years upon population between 15 to 65 years. What does this suggest you of? So dependency ratio means the non-earning population, that is less than 15 and more than 65 years, who is dependent on the earning population, that is 15 to 65 years. Okay, I hope this is clear. This is usually the dependency ratio. Next, talking about the literacy rate. Okay, so literacy rate का formula क्या होता है? Literacy rate is total number of literates. Okay, total number of literates upon total population more than equal to 7 years into 100. Okay, what is the formula for literacy rate? Total number of literates upon total population of more than equal to 7 years into 100. As 100 is the multiplier and A is part of B, therefore this is a proportion as it is expressed in percentage. Literacy rate is a proportion as it is expressed in percentage. Okay, and the current literacy rate of India according to census 2011 is 74%. Okay, the current literacy rate of India according to census 2011 is 74%. The highest literacy rate in India is seen in the state of Kerala. Highest literacy rate in India is seen in the state of Kerala, whereas the lowest literacy rate in India is seen in the state of Bihar. Lowest literacy rate is seen in the state of Bihar. याद रख लेना. If they talk about males and females, so please remember around 82% of Indian males are literate, whereas around 65% of Indian females are literate only. Okay, 82% of males and 65% of Indian females are literate. याद रख लेना. Okay, so what do we mean by literate? So please remember, literate means if a person is able to read, write and understand any one of the language. It is not compulsory of Hindi, English, anything. So if a person is able to read, write and understand any one of the language, the person would be considered as a literate. Okay, and the denominator would be more than equal to 7-year-old population only. याद रखना. Moving further, talking about the different systems that we have for data collection and analysis of our population. So for demographic purposes, we have 5 different types of systems. The first and the widely accepted one is the census of India. First and the widely accepted one is the census of India. Census is conducted every 10 years. So the frequency of census is every 10 years. So census is conducted every 10 years, every decade. Okay, the first census in India was conducted in the year 1871. First census in India was conducted in the year 1871. First disability census in India was conducted in the year 1881. The next census, second census, was the first disability census in the year 1881. Okay, usually census stops on which date? So please remember, census usually stops on 31st of March. Census usually stops on 1st of March. Okay, census usually stops on 1st of March at 12 hours. Next one, if they ask about the year of Big Indian Divide, the year of Big Indian Divide or the year of Great Indian Divide is the only year when the population of India was seen to be declining. Okay, so it was the only year when the population of India was declining. Okay, this is known as the year of Big Indian or the Great Indian Divide. It was the year of 1921. So year 1921 is considered as year of Big or Great Indian Divide. Moving further, this census comes under which ministry? So please remember, census comes under Home Affairs Ministry. Census is the responsibility of Home Affairs Ministry. Next, we have the second data collection system known as SRS. SRS is your Sample Registration Survey. Okay, Sample Registration Survey of SRS is conducted every 6 months. Yeah, the frequency of SRS is every 6 months, and it is the only dual record data system. Okay, याद रख लेना, it is the only dual data record system. ठीक है, याद रख लेना. So only dual data record system is SRS, Sample Registration Survey, and therefore it is a great system. Okay, it is reliable. Next one, if we talk about SRS, there are various indicators which are considered in an SRS. Okay, those are infant mortality rate, under 5 mortality rate, neonatal mortality rate, crude birth rate, crude death rate, growth rate, and lastly maternal mortality rate. याद रख लेना. Okay, so there was a controversy in December 2020 session. A question was given by NBE that all of the below given indicators are part of SRS, Sample Registration System, except, and the options were IMR, CBR, CDR, and MMR. So what should be your answer? Examiners thought MMR should be an answer because there is a separate system for MMR under SRS. But Though there is a separate system, it usually comes under SRS. It is not an exception. Therefore, the case went to the court, and the court asked the census commissioner. Therefore, the census commissioner have told in a written statement that MMR is a part of sample registration system. So, therefore, all the individuals who scored 149 in December examination and who marked this question wrong, they can definitely go to NB and ask for their 1 mark, because that was a controversy. Okay. So sample registration survey or ministry comes under Ministry of Home Affairs again. याद रख लेना, sample registration system also comes under the Ministry of Home Affairs. Okay. Next, talking about the third data collection system, which is NFHS, National Family Health Survey. Okay, third is your National Family Health Survey. Frequency is every 5 to 6 years. Okay, so usually NFHS is conducted every 5 to 6 years, and it is conducted by Indian Institute of Political Sciences. Okay, it is conducted by Indian Institute of Political Sciences, Mumbai. याद रख लेना. Okay, how many rounds have been conducted till now? So 4 rounds of NFHS have been conducted till now, starting from 1992. Next, the fourth data collection system is DLHS, that is District Level Health Survey. Fourth is your District Level Health Survey. The frequency is 4 to 5 years. Okay, so DLHS occurs every 4 to 5 years, and again 4 rounds of DLHS have been conducted till now. Next, the last and the fifth data collection system of India is a very important one, that is Vital Registration System. That is known as the Vital Registration System. According to this system, birth of a child should be registered within 21 days. Birth of a child should be registered within 21 days. Whereas death of an individual should also be registered within 21 days. Death of an individual should also be registered within 21 days. And marriage should be registered within 30 days. Marriage should be registered within 30 days. Yaad rakhna. Birth and death within 21 days and marriage within 30 days. If a question comes like an RI couple has delivered a child abroad, okay, an RI couple has delivered a child abroad, then the birth of a child should be registered within 60 days of arrival. So yaad rakhna, if a child has been delivered abroad, the birth of a child should be registered within 60 days of arrival. I hope this is clear. Moving further now, talking about the population pyramid. I have already discussed about population pyramid in images, because usually images can come in the examination for population pyramid. Okay, just telling you, population pyramid can be of two types, two shapes mainly. First is a pyramidal shape, something like this, and second is a spindle shape, something like this. Okay, you can just refer to the image based part also. Okay, this is a graph. So pyramidal shaped population pyramid is usually seen in cases of developing countries. Okay, pyramidal shaped population pyramid is seen in developing countries like India, whereas the spindle shaped of population pyramid is seen in cases of developed countries. Spindle shaped of population pyramid is usually seen in cases of developed countries like USA vagara. Okay, so here the shape in developing countries is pyramid, shape in developed countries is spindle. Apart from this, symmetry is important. In developing countries, the graph is usually asymmetrical, because the symmetry usually indicates about sex ratio, and as we are quite aware, in developing countries usually the sex ratio is not proper. Okay, females are less as compared to males, therefore there would be asymmetry seen in cases of developing country pyramid, and in developed country the graph would be more symmetrical. I hope this is clear. Now talking about the next one, moving further, apart from this, now we are left with some important thing, that is occupational health. We will discuss about occupational health for today, and then we'll call up the session. So talking about occupational health would be occupational health would talk about the diseases which are due to occupational exposure, which are related to a particular profession, right? So now occupational diseases can be due to various physical agents, chemical agents, or biological agents. So the physical agents responsible for causing different types of diseases are, first of all, when a patient is exposed to extreme heat. Okay, when a patient is exposed to extreme heat, the patient can land up in heat exhaustion or heat stroke. The patient can land up in heat exhaustion or heat stroke. If a individual is exposed to excessive cold, okay, usually like in Siachen glacier, the person can land up in trench foot or in frostbite, or finally in hypothermia. Okay, so trench foot in moist cold, then dry cold mein there would be frostbite, and lastly there would be hypothermia. Yaad rakhna. Next, if there is excessive exposure to light, then that can definitely lead to cataract. Excessive exposure to light can lead to cataract. Excessive exposure to pressure. Mostly in cases of low pressure, we have a disease. Okay, if a person is exposed to low pressure, the person can land up in decompression sickness, and this decompression sickness is also known as Kazan's disease. This decompression sickness is also known as Kazan's disease. So Kazan's disease or decompression sickness is due to exposure to low pressure. When a person suddenly goes from high pressure to low pressure, which is usually seen in which profession? It is usually seen in deep sea divers. It is usually seen in deep sea divers when the person experiences nitrogen effervescence in the form of bends, chokes, paralysis, and also air expansion like in emphysema vagera. Okay, so usually it is seen in cases of Kazan's disease, and when the person is actually given a hyperbaric oxygen therapy and the person is kept in recompression chambers. Next one, talking about noise now. Okay, talking about noise, excessive exposure to noise can land up the patient in deafness, definitely. Okay, and we have already discussed about the sound levels. So sound level, prolonged and chronic exposure to a sound of more than 90 decibels can land up the patient in auditory fatigue. A chronic and prolonged exposure to a sound of more than 100 decibels can land up the patient in permanent hearing loss, and a sudden sound exposure rather of 150 to 160 decibels can land up the patient in rupture of air membrane, tympanic membrane or eardrum. Lastly, radiation. Radiation exposure definitely can be teratogenic for pregnant females. It will have adverse effects on the fetus. Second, it will also lead to many of the cancers. Yaad rakh lena, it will also lead to cancers mostly. Okay, so cancers are associated with radiation exposure. I hope this is clear. Also, radiation can lead to cataract vagera. Moving further, talking about chemicals. There are different types of chemicals like lead, mercury, vagara, all these metals, arsenic, they can lead to poisoning. And next one are your pneumoconiosis. Pneumoconiosis means nothing else but occupational lung diseases, on which we have had a detailed discussion in respiratory pathology and medicine. But now we'll just discuss about the important points over here in PSM2. Right. Next, pneumoconiosis are due to occupational exposure to the inhalational dust. Right. Now talking about some biological agents that can land up the patient in diseases. Those are bagasosis, bicinosis, leptospirosis, and anthrax. We'll discuss about bagasosis and bicinosis because they are a type of pneumoconiosis only. But leptospirosis and anthrax are due to organisms like Leptospira and Bacillus anthracis. Right? Both of these diseases are common in farmers. Okay, both of these diseases are common in farmers. Leptospira is actually found in rat urine. Yaad rakh lena. Okay, moving further now. Talking about pneumoconiosis now. If we talk about pneumoconiosis, it is nothing but occupational lung diseases due to inhalational exposure to occupational dust. Right? Now, there are different particle sizes, but the most dangerous particle size responsible for causing pneumoconiosis is 0.5 to 3 micron. Most dangerous particle size will be 0.5 to 3 micron. Most common pneumoconiosis out of all is silicosis. Most common pneumoconiosis or occupational lung disease out of all is silicosis. Okay, if we talk about silicosis now, guys, so please remember silicosis is due to exposure to silica. Okay, silicosis is due to exposure to silica dust. Okay, the disease associated with silicosis is tuberculosis. TB is commonly associated with silicosis, and the occupation in which silicosis is commonly encountered are the cement industry workers, glass industry workers, bauxite mining industry workers, okay, and also sand blasting industry workers. याद रख लेना, in सब profession में silicosis is much more common. Okay, here you can also remember about radiology, important finding from patho radio medicine. Chest x-ray of silicosis shows two important findings. First is eggshell calcification. याद रख लेना, two important findings. First is eggshell calcification and second is reticular nodular opacities. And this reticular nodular opacities of silicosis on chest x-ray have a peculiar name known as snowstorm appearance. It is known as snowstorm appearance. So the two chest x-ray findings of silicosis would be eggshell calcification and snowstorm appearance. Moving further, now talking about anthracosis. Anthracosis is also known as coal workers pneumoconiosis. It is also known as coal workers pneumoconiosis. Okay, it is due to exposure to the coal dust. It is due to exposure to the coal dust seen in coal mining industry workers. It is seen in coal mining workers. Okay, yaad rakh lena. And the disease commonly associated with it is progressive massive fibrosis, PMF. Progressive massive fibrosis is commonly associated with anthracosis, where there is extensive fibrosis of all the lung parenchyma. Moving further, talking about asbestosis now. Asbestosis is due to asbestos exposure, right? And it is common in cement industry or construction industry workers. It is common in cement industry or construction industry workers. The common disease associated, the most common disease associated with asbestosis are lung cancers. But which lung cancer? So please remember, adenocarcinoma or bronchogenic carcinoma is the most common disease associated with asbestosis. And if they ask about the most specific one, then your answer should be malignant mesothelioma. Then your answer will be malignant mesothelioma. Yeah, the most common is adenocarcinoma or bronchogenic carcinoma. Most specific is malignant mesothelioma. Moving further, talking about byssinosis now. Byssinosis is usually due to cotton fiber dust exposure. Byssinosis is usually due to cotton fiber dust exposure, and byssinosis is usually encountered in textile industry workers. Usually it is encountered in textile mill workers. ठीक है, कपड़े का जिनका ये होता है, okay, textile mill industry or textile industry workers. Okay, and a peculiar finding of byssinosis is Monday chest tightness. When the patient will resume work, the patient will experience chest tightness. That is known as Monday chest tightness, seen in byssinosis. Next, talking about bagasosis. Bagasosis is due to what? So please remember, bagasosis is due to exposure to bagasse or molasses. Okay, याद रख लेना. Bagasosis is due to exposure to bagasse or molasses. Okay, this bagasse or molasses is nothing but the waste product while sugar processing. So in sugar mill workers, it is usually encountered. याद रख लेना, bagasosis is usually encountered in sugar mill workers. Okay, when the sugar is processed and bagasse or molasses is released, and this bagasse or molasses can be inhaled and can lead to bagasosis. Along with this, a question in FMGE June 2020 was asked that bagasosis is commonly encountered in, and sugar mill industry was not given an option. So the other option which was given was cardboard industry workers. Yaad rakh lena. So we actually tend to forget this. So please remember, cardboard is usually made with the help of that bagasse or molasses, which is the waste product of sugar. So that cardboard industry workers are also at a risk of developing bagasosis. So usually this bagasse or molasses have these minute particles which are actually mixed with the air. So to prevent bagasosis, usually 2% of propionic acid is sprayed on these particles. Okay, so 2% of propionic acid is sprayed on the bagasse or the molasses for preventing it from actually mixing it with the air. Okay, 2% of propionic acid. Question have been asked earlier. Yaad rakhna. Which is the organism responsible for causing bagasosis? So important one, the organism responsible for causing bagasosis is known as Thermoactinomyces saccharine. The organism is known as Thermoactinomyces saccharine. Okay, shakkar, saccharine, easy. Next, talking about farmer's lung. Usually farmer's lung is due to exposure to moldy hay. Farmer's lung is due to exposure to moldy hay, and that moldy hay contains which organism? That moldy hay contains organism known as Micropolyspora feni. Okay, farmer's lung due to exposure to moldy hay, which contains organism known as Micropolyspora feni. Next, compost lung is actually due to exposure to the compost. Okay, compost lung is actually due to exposure to the compost, and the organism responsible is the fungus known as Aspergillus. Okay, the organism responsible is known as Aspergillus. Next one is your bird fancier lung. Okay, so bird fancier lung is commonly encountered in bird handlers who are commonly exposed to bird droppings. Okay, so bird droppings jo hote hain, exposure to these bird droppings can land up the patient in bird fancier lung. One more disease is commonly associated with bird dropping exposure. Okay, bird dropping or pigeon dropping exposure commonly. So when a patient is exposed to pigeon droppings, the person is at a risk of developing a fungal disease known as histoplasmosis. Histoplasmosis, also known as Darling's disease, also which resembles tuberculosis closely. It is due to exposure to pigeon droppings. Okay, and bird handlers can also be at a risk of developing bird handlers pneumonia. Okay, bird handlers are also at a risk of developing bird handlers pneumonia due to exposure to the bird feathers. जो feathers होते हैं ना, उसका अगर exposure हो जाता है, the person can develop bird handlers pneumonia due to organism known as Chlamydia psittaci. Due to organism known as Chlamydia psittaci, therefore that is known as psittacosis. The disease is also known as psittacosis. Next, now we have done with all the organic or the pneumoconiasis that are there. Now we'll actually discuss about a metal poisoning, that is plumbism. Okay, that is plumbism. Plumbism means what? Lead poisoning, because lead is also known as plumbum. So plumbism or lead poisoning is also known as painter's colic. And why it is known as painter's colic? So it is known as colic because it is commonly associated with abdominal pain. First thing. Second, Painters, because usually the paint which is there that contains lead, and painters are at a higher risk of developing lead poisoning due to a constant exposure to this paint. Okay, therefore lead poisoning or plumbism is also known as painter's colic. Now, if they ask you about the most common source of lead in India, so the most common source of lead in India is petrol or gasoline. Most common source of lead in India is petrol or gasoline or the vehicular exhaust. Most common source of lead in India is petrol, gasoline or vehicular exhaust. Moving further. Now, if they ask you which is the first sign of plumbism, so please remember, if they ask you, the first sign of plumbism would be pallor. Okay, so please remember, the first sign of plumbism or lead poisoning is pallor. Yaad rakhna. And pallor is also the most consistent sign, okay, which is seen throughout the course of lead poisoning. So the first and the most consistent sign of plumbism is pallor. Yaad rakh lena. What are the other things seen? So usually we can see abdominal pain of colicky nature. We can see pallor, which is the first and most consistent sign. And if we actually see the gums of these individuals, we can find Burtonian lines. What are Burtonian lines? Important ones from FMT also. So Burtonian lines are bluish line found on the gums due to lead deposition. Okay, due to lead deposition on gums, we can find Burtonian lines. Okay, yaad rakhna. And if we perform a peripheral blood smear of a lead poisoning patient, we can find two findings. Okay, first is a basophilic stippling. First is the basophilic stippling, when we actually can find, please remember, just a minute. Yeah, when in the RBCs we can find blue color stipples. Okay, so this is known as basophilic stippling. Okay, blue color stippling would be found in the RBCs. This is known as basophilic stippling. And second one would be microcytic hypochromasia. Second one is microcytic hypochromasia. I hope this is fine. Now next, if we talk about test, okay, the test which is the best test for us for diagnosing lead poisoning is CPU levels. What are CPU? Coproporphyrinogen levels in the urine. So coproporphyrinogen levels in the urine is the best test to diagnose lead poisoning. Apart from this, you can also assess lead levels in blood and urine. Now, if we talk about the treatment of lead poisoning, so for treatment of lead poisoning, usually we have some chelating agents, and the chelating agents used for lead poisoning are EDTA and penicillamine. Chelating agents used are EDTA and penicillamine. Okay, this was all about lead poisoning that you need to know. Okay, mercurial poisoning is also common. Mercurial poisoning you will read in FMG. Okay, we'll discuss it over there. Now talking about the most common occupational cancer. If we talk about the most common occupational cancer, we are not talking about cancer only. Now they have asked us about occupational cancer. Okay, so the most common occupational cancer is skin cancer. Most common occupational cancer is skin cancer. And skin cancer kaun sa hota hai? Squamous cell carcinoma. So the most common occupational cancer would be squamous cell carcinoma of skin. Yaad rakhna. Next, if it and it is commonly associated, the skin cancer is commonly associated with radiation. Yaad rakhna. Next, if they talk about PVC exposure, PVC means polyvinyl chloride. So if a cancer associated with PVC exposure is known as angiosarcoma of liver. Yaad rakhna, the cancer associated with PVC exposure is angiosarcoma of liver. Important one. And next, if they ask about wood dust exposure, okay, so please remember, with wood dust exposure, usually nasopharyngeal carcinoma is common. Okay, so the cancer associated with wood dust exposure is known as nasopharyngeal carcinoma, with the most common site for which is the fossa of Rosenmiller, and it is common in Chinese population. Right, so nasopharyngeal carcinoma or any of the paranasal sinus carcinomas are commonly seen in wood dust exposures. I hope this is clear. Moving further, talking about the Factory Act 1948. Okay, so the factory, what is a factory actually? So if more than equal to 10 people are working together with power or electricity, it is known as a factory. Or the second definition is more than equal to 20 people are working together without power or electricity, it is also known as a factory. Okay, so which comes under the Factory Act. So this Factory Act came into existence in the year 1948. Factory Act came into existence in the year 1948. And important findings that you need to remember about Factory Act is, first, the child between 0 to 14 years of age could not work. Yaad rakh lena, child between 0 to 14 years of age could not be forced to work. That is child labor, and which is actually illegal according to the law. Right? Please remember this. Okay. So child between 0 to 14 years is unable to work in India. But if the child is between 15 to 18 years, so please remember the child between 15 to 18 years is allowed to work, but the terms and conditions are, first of all, the child will only work in daylight. Second thing, the child would work maximum 9 hours per day, 48 hours per week, and lastly, he'll only work along with overtime only for 60 hours per week. Okay, along with overtime. Yaad rakhna. Next, if I talk about the safety officer, okay, usually if I talk about the safety officer in a factory, so there should be one safety officer per 1,000 workers. Yaad rakh lena, there should be a one safety officer per 1,000 workers and one welfare officer per 500 workers. ठीक है, याद रख लो ये. So these are the important things from occupational health also that you all need to remember. I hope this is all clear to you. We have discussed about energy, nutrition, demography, epidemiology, RCH also. Now we are left with communicable diseases and entomology that will be discussed in the last session along with biostatistics. Whereas the other shorter topics which we are left with, like euthenics, family planning and contraception, then biosafety levels, health communication methods, international health, bioterrorism, then sensitivity, specificity, that is screening of a disease, surveillance, or time distribution of disease, or some other health and disease chapters. Those would be considered in the next session now. Okay, so please remember, we will call up the session for today, and all of these will be discussed in subsequent two sessions. Okay, so I hope all of you have understood this and you are attentive throughout. Thank you so much for the session. Let's meet in the next session of Spark. And till then, goodbye, good luck. Don't forget to get added in the FMG Telegram groups where you'll get all the updates, all the questions, because now the frequency of these sessions will be increased. And we look forward to see you in FMG classrooms also with us for the chanting sessions. Along with that, also you should attend for the test and discussion series of AFMG. And all the very best. I hope all of you will study. And thank you for today's session.